Hi everyone, I'm Katie Zappel, Director of Marketing and Communications for Rogers Behavioral Health. Thank you for joining us today for our Facebook Live Q&A to help mark National Eating Disorders Awareness Week. Today we have with us Dr. Stephanie Eken, Rogers Regional Medical Director, and Dr. Brad Smith, Medical Director for Rogers Oconomowoc Campus and Eating Disorder Recovery. They'll be sharing their expertise today on the signs, symptoms, and severity of eating disorders. If you have any questions throughout our discussion, please post them in the comment section and we'll answer them at the end of our discussion. Dr. Eken and Dr. Smith, thank you for being here.
Thank you so much for having us, Katie, today. I know I'm excited. I'm excited to be here with Dr. Smith as well, even though we don't work in the same geographical area. We get to interface and talk about eating disorders, so this is exciting. And I think it's really an important topic. The mortality rates are high in eating disorders, so it's a very serious disorder to talk about. And I'm also happy to represent the needs of children and adolescents as part of what I'll be talking about. And honestly, just to talk about what's been happening in the pandemic as well, because we've seen a lot of people seeking treatment during the COVID pandemic around eating disorders.
Thank you. And similarly, I'm very excited to be here with Dr. Eken and with Katie. As Dr. Eken indicated, we share patients a lot going back and forth to our different locations. And we also spend a lot of time together in terms of trying to develop treatment programming in our system. So it's a pleasure to be here today for this very important topic. As Dr. Eken was indicating, the severity of these illnesses are quite significant, and we always want to pay attention to that because we get excited sometimes about our treatment opportunities and our improvements in the treatment that offer hope for individuals, and yet we have to keep in mind the severity of these illnesses is one of the main reasons to keep searching for more advanced and more effective treatments. And I'm working primarily with adults in our programs, but I do see adolescents and kids on occasion. But this is one of the reasons why we wanted to try to represent the age spectrum in terms of, Dr. Eken's seeing more children and adolescents, and I'm seeing more adults in our system. So thank you everyone for joining today.
Thank you. And you both mentioned the high mortality rate of eating disorders. In fact, studies are showing that the eating disorders now have the second highest mortality rate of all mental health disorders, and that they're surpassed only by opioid addiction. On top of that, more than 10,000 deaths each year are the direct result of an eating disorder. That's one death in every 52 minutes. I personally found these statistics extremely shocking. Dr. Smith, can you speak to these numbers and the severity of eating disorders?
Sure, thank you, Katie. When we think about the mortality rate, especially with eating disorders, one of the ways I think about this is that any mental health issue tends to have a mortality rate associated with it based on primarily suicide risk. And we see that in many different mental health issues like depression, anxiety disorders, schizophrenia. And so eating disorders are similar in the sense that the chronic struggles that individuals have, the types of symptoms and difficult thought patterns that people are dealing with lead to suicide risk just by way of having the eating disorder. In addition, as we'll talk about more today, most individuals with an eating disorder also have some other co-occurring mental health issue like depression or anxiety that also carries its own suicide risk because of those symptoms and struggles. So you have this suicide risk as a core baseline risk for individuals with eating disorders. Then on top of that, you have all of the physical complexities and problems that develop from eating disorders, which carry mortality risks and morbidity risks in and of themselves. So you have this combination of the suicide risk that comes from long-term or even short-term struggles with mental health issues. And then you have the mortality risk from physical health problems that develop from the eating disorder, the physical toll that the eating disorder takes, and then the unfortunate risk of death that can occur because of these symptoms and behaviors.
Yeah, I just always think about, people, I don't know, always think about this part, but I always say eating disorders, it affects you from the tip of your head to the tip of your toes. So like every organ system can be impacted. And so that's where, you know, the mortality issues can come from, is because it really has a whole body impact that can be profound.
And I think, you know, we were speaking about mortality risks, but there are also a lot of physical health problems that wouldn't necessarily lead to death, but are really challenging and problematic for people to deal with as they can start to have problems with their heart, their liver, their bones, and then physical issues with, you know, with the skin, their hair. So a lot of very concerning features that wouldn't necessarily lead to death, but can lead to physical problems that a person has to deal with.
Absolutely. Or are there even mental health concerns? Because I just think about fertility being infected in men and women with eating disorders too, right? Which can lead to a whole host of other issues for them if they're experiencing long-term fertility issues that have been impacted perhaps by malnutrition from an eating disorder. So lots of ways that people can be impacted.
I think that adds to the complexity of trying to help people with eating disorders, and why you see most of the times treatment programs or places where people can receive treatment is typically a team approach. We need primary care clinicians, we need therapists, we need psychiatrists, we need a dietitian, we need a full team approach, we need nurses in our higher levels of care. So it's such a complex set of illnesses that require attention from so many different disciplines. So it's really quite rewarding when those teams come together, and quite challenging if you don't have the good fortune to be in a team like that, to be trying to help someone.
Absolutely.
Thank you. Yeah, it's really eye-opening just how far-reaching the dangers are, and just making it so important that we're having conversations like this, not only this week during NEDA week, but always. So thank you. Dr. Eken, can you tell us a little bit about the different types of eating disorders?
Yes, and obviously we could talk about this part for a long time too, but I will try to categorize, you know, these eating disorders to help people. I think what people know mostly is about anorexia and bulimia, because that honestly tends to be what's out in media the most. So, but I like to think mostly about, you know, there's restrictive type of eating disorders like anorexia that would certainly fall into that could lead to weight loss. And then there's something called ARFIT, which is avoidant restrictive food intake disorder, which is actually a newer diagnosis for us. Although it's been around for a while, we just have a new name for it, I think, which a lot of people would see as extreme picky eating, like perhaps someone cannot eat more than 5 items, 10 items, and require supplementation to keep up their weight. So I think about both of those as leading to, you know, weight loss. It doesn't mean someone's underweight by certain standards that we like to uphold, but that it can lead to weight loss and malnutrition and require supplementation. Things can go into a lot of categories though too, and so you can have purging that can be part of anorexia certainly as well. But there is another category that I think people are very familiar with, like around binging and purging types of eating disorders. So bulimia being the one that people most often know, in which there are these episodes in which people feel out of control and they eat you know, a large amount of food, and then they may do what we would call compensatory behaviors, something like purging, so something like vomiting or using laxatives, diet pills, those type of things, in order to reduce, right, the calories that they've taken in. But there's also binge eating disorder too, in which you have binges and you don't have the purging that goes along with it, that I think people are becoming more familiar with as well. I think it's gotten more discussion over the past few years. And then there's a whole, like, there's other categories of eating disorders I think people aren't as familiar with. And so one of them is called orthorexia. And we actually see it quite a bit in treating eating disorders, in which people are eating in an incredibly clean way. And when I say clean, it might be like all organic types of food. They take really long times to prepare their food and make sure it's from an organic source. Leads to, you know, weight loss, those type of things for them. Or there's something called diabulimia too, in which people have diabetes, in which they may use insulin in order to manipulate or change their weight based on their concerns about their body weight. I will say, though, that there are so many people also walking around who have what we would identify as sub-threshold symptoms. So they don't quite meet the criteria for one of these eating disorders, but are still really struggling with their eating. It's common for us to see this in kids with anxiety and adults, or OCD or depression, that it's part of what's going on with them. And to be honest, I feel like in the world of social media that people experience these days, the ideas about body image and body weight have been so profoundly impacted by that people are thinking about, what do I look like, even more at a younger age now than we would have considered it before, because also a lot of the images we're being fed are not even real, and you don't know that necessarily. So that's a really broad overview. I don't know, Dr. Smith, if you want to add anything else in there, because you can have a whole talk about any of these eating disorders.
Right. And so there are many, and then, as you said, many sub-threshold where it doesn't rise to a level of a specific category, but it's profoundly affecting someone. Yes. And I think also about the way it's common for symptoms and behaviors to migrate over the years, right? For somebody with an eating disorder, they may have developed at a younger age. It may consist of primarily restricting behaviors and urges to restrict. And then as time goes on, they may later develop problems with binging and purging. It may then, at a later point in their life, become more of an exercise compulsion. So these symptoms and behaviors migrate over the years. So it leads to sometimes differing diagnoses over the course of time. And that kind of, I think, leads into one of the reasons why we have gone at Rogers, most of the clinicians have gone towards more of thinking of eating disorders in what we call a transdiagnostic way, where we have to have these specific diagnoses like anorexia or bulimia to help us understand how to do research, to help us understand how to do billing and coding, and to help us understand illnesses in a scientific way. And yet, when we're trying to help people with the individual issues that they have, it tends to be a little more helpful for us to think of this in that transdiagnostic way, where it's more about what the individual is experiencing with symptoms and behaviors versus what exact category we're calling it, because we know that many people with eating disorders, their symptoms and behaviors will migrate or change over the years.
Right. I think that's a great point. Yeah, just because you have anorexia when you're younger does not mean that that's what it'll be if it resurfaces when you're older. I think that's really important, and that the symptoms are what we're going after.
That must be extremely hard then to kind of uncover and diagnose as a mental health professional. Are there any symptoms that are kind of classic symptoms that maybe a family member could be watching for?
Sure. And I think when we get asked this, I think of this in two main categories. One is I think about changes that people might recognize in someone's emotional state or psychological state, which can also be associated with their behaviors. And I think about the changes that we might notice in physical issues or physical appearance. And those two categories kind of encapsulate a lot of the types of changes that would represent symptoms for people. So when it comes to emotional or psychological changes for people, we're looking for, whether somebody has a major change in how they're interacting with food, with meals, with mealtime, with family and friends, changes such as, more isolating and being afraid to eat around other people, starting to use behaviors at the mealtime that would seem unusual to most people without an eating disorder. So could be as simple as, hiding food or cutting food into very small pieces. We look for, changes that we might see in other mental health struggles too, like more isolation or distancing oneself from friends or from their social network. So these types of emotional and psychological changes are very common. You might also see, significant mood swings or anxiety increases that could represent a co-occurring type of mental health issue at the same time, because sometimes these things come on together or at the same time. And on the physical side, I mean, some of the physical changes will be things more that maybe you would see if you're that a medical provider would notice, things such as laboratory value changes or changes in a person's vitals, such as their blood pressure or pulse, or most, classically you might see weight changes, and it could be, either direction. Pediatricians, primary care providers would be looking for significant changes in the growth chart and where somebody's tracking on their growth chart. They might be noticing, other physical changes in a person's, if they get malnourished, they would likely start to have these fine hairs called lanugo on the skin. They may start to see changes in skin blemishes or calluses on people's hands if they're engaging in purging behaviors. And then, more serious kind of alarming type physical changes, like if somebody were to start coughing up blood, for example, would be a medical urgent situation where people can develop bleeding problems from purging or vomiting excessively. So we have these two major kind of categories of changes that we often see for people when they're in the midst of an eating disorder that they may not have been willing or able to share with someone else. So some of those changes will be things friends and families might notice. Some would be things that their medical provider might notice on a well-check visit or just a regular checkup. And certainly, a lot of times teachers, coaches, people who are used to, assessing somebody's physical abilities might see changes that before family members might see it. If somebody starts having problems with energy level or problems with their strength, that may be noticed by a coach in a sport before it would be noticed by a family member at home. So a lot of different types of changes can be going on to help alert people that there's a problem occurring.
Yeah, and I will just say sometimes too in our adolescent population, right, that their friends might be one of the first ones who notice as well. So
right.
At school, if they're throwing their lunches away or making lots of comments about their body and their dissatisfaction with their body can be important signs. So sometimes their friends will actually be the ones that raise the red flag. I'll just say too, when I think about growth charts from a pediatric standpoint, it's, we get tricked into thinking that it's just a weight thing, but also like it's important to think about height in a child as well. So when they're off their growth curve for whatever reason, like Dr. Smith mentioned, up or down on weight, if there's a significant change from where they've been tracking both weight and height wise, those should just lead to questions to understand what might be happening for someone. I also like to say that what can start off as something that seems healthy to a family member for someone can snowball and become something that's really unhealthy. So someone might say, oh, I want to change my eating because they've been, eating unbalanced, because you'll hear us say like there's no bad food, but like a lot of people will label foods as good or bad, but there's balance in how we eat. And so maybe somebody's wanting to change the balance in how they eat, and it can go too far. And I think sometimes it's hard to recognize when it started off as a healthy thing and there's been some improvements, like maybe in performance for sports or just overall energy levels, and then it starts to go too far.
Yeah, I think I use that example quite often in sharing with individuals struggling with this or their family, that the most classic story that we'll hear is what Dr. Eken just said, where somebody started off trying to make changes with good intentions, trying to make changes towards what they believe would be a healthier way of eating, a more balanced way of eating, incorporating more physical activity, all the things that they would hear about what would be healthier. And then at some point it gets away from them, or the positive feedback about the changes starts to spark more intensification of those efforts. And then it just keeps going into a pattern where at some point someone really doesn't really have control over it to any significant degree.
Mm-hmm.
Yeah, that was incredibly eye-opening, and for me, and I'm sure a lot of the people listening today, it's just there's so many signs that I think historically we would have never thought of as being connected to an eating disorder. I think historically it was just really someone's drastically losing weight. And it's just so important that we're learning just all the other things that could be going on. Along with that, Dr.
Can I add something really fast,
absolutely.
Katie? Because I think that one of the good things is that I think our fields, medicine, psychiatry, psychology, have been getting better at getting the word out and getting more awareness, so that the individuals who might notice something, it has expanded over the years to beyond a medical office or a psychiatry or psychology office to teachers, families, and that's been great. We still have a long way to go. That's why these awareness weeks help in that effort. But there's a lot more awareness among especially kids in school, young adults in college. There's a lot more awareness going around. So it goes back to Dr. Eken's point that a lot of times it will be the friend or friend group that notices something before anybody else would, because everybody in their age range is more familiar with eating disorders than, say, their parents' age range might be aware of it.
Absolutely. Thank you. So we've talked about some of the signs and symptoms that we may, that we're learning more and more about. Dr. Eken, is it common that when somebody's struggling with an eating disorder that that's the only mental health disorder they're struggling with? Or I think what we've kind of touched on already is that there are often other things going on. Could you tell us a little bit about that?
Yeah, I mean, honestly, with almost anything we treat in psychiatry, there's usually not just one thing going on, right? And so the same is true for people with eating disorders. There have been a variety of studies, and many of them showing that, upwards of 90% or more of people have some other, what we would call co-occurring illness happening with their eating disorder. So very commonly seeing things like anxiety, depression. Depression is probably the most common thing that we see among people with eating disorders, OCD, trauma. And that's not even discussing like the other medical things that might be going on for them, right, related to their malnutrition, purging. I think the tricky thing too can be, because eating disorders, there's this malnutrition component, and anyone who's malnourished as well, we know that they can have symptoms that look like depression or anxiety as well. So they can have a co-occurring actual anxiety disorder, but some of it can actually be due to how malnourished they are as well. So that's why it's so important to have them, treated by a team, as Dr. Smith mentioned before, in which we have a meal plan and, psychiatry and medical doctors and everyone involved to try to come at this from multiple angles. But yes, co-occurring illnesses, that's the most common thing for us to see. And so we're going to try to do a variety of things to address those. Number one, we're going to try to understand what's going on, if they have multiple diagnoses, and we can use therapeutic strategies, to help them. And we also may use medications, but also addressing their malnourishment in and of itself can be something that is really helpful for people who have eating disorders and other symptoms happening.
Thank you.
I would agree with that. I think that the last piece that you touched on, Dr. Eken, about the nutrition being so important for the treatment of the other co-occurring issues, we see that first of all that individuals who are malnourished or have lost weight rather rapidly, that they usually lose their protein and amino acid stores, which are very important in terms of generating new neurotransmitters, which is the key for most changes in terms of mood and depression and anxiety disorders. It relies upon the regeneration or production of neurotransmitters. So if you don't have those building blocks, you really aren't going to be able to produce that, even if you're engaging in good therapy or having medications on board. So we need those building blocks there, and that may help in and of itself. And then the medications, the therapy can work better when the nutrition is stabilized. I also am cognizant that, historically there had been a thought in the field that if you have these other co-occurring issues, that they would get better once the eating disorder was stabilized. And that, the research over the years has really thrown that into question. Really, that's not the prevailing theme any longer, or the prevailing thought. Where most of the time, the co-occurring issue, if you really do a careful history, tends to occur before the eating disorder actually starts. And so it's not likely that treating the eating disorder will be all that is necessary. So we really try to approach all of the mental health issues at the same time and treat them all, because we believe that it is very important, obviously, for the eating disorder to get stabilized and treated, but the other co-occurring issues will likely improve some with that eating disorder improvement, but it's probably not going to be sufficient to get the person to a good state of recovery with regards to their depression and their anxiety or whatever other co-occurring issue they have.
Yeah, and I think some people feel like when they've gone through eating disorder treatment that that only their eating disorder has been addressed, which then I feel like, sometimes puts them at risk for recurrence of their eating disorder if their trauma or anxiety or depression haven't been, addressed as well. So I think that's a really, important point. And you'll hear any family member or patients of mine, if they have been malnourished, and they're experiencing, a lot of symptoms, is food is your best medicine if you're in a restrictive, malnourished state. And then, once we've had some stability there, then addressing, with therapy and medications can be really helpful to address the co-occurring issues.
Thank you. So I feel like we've already addressed some pretty important myths out there about eating disorders. Are there any other common myths that you would like to address today?
Yeah, well, we've touched on a lot of them, but I think it's important to call out a few of them. And I know Dr. Smith will want to add on some of these, but I think the most common one, and we have alluded to this, is that having an eating disorder is a choice. I see it just like any other illness we may experience in our lives, right? People don't choose to have asthma. They don't choose to have, diabetes. People don't choose to have eating disorders as well. And it's also not, there's long been this idea that it's a parent or a family member's fault too, that one might have an eating disorder. There are certainly people that there can be environmental factors that don't help them, but it does not, no one's at fault for an eating disorder, and it's not a choice. And so I think that's really important for people to understand, because I do think historically there's been blame for families and for patients in eating disorders. And I think what we should instead be talking about is hope and recovery, right? So, because I also think that for a while people felt like there wasn't a lot of hope in eating disorders. And I do believe that people can get better and that they can have, a really fulfilling life, and that they can overcome their eating disorder symptoms. And so we see it over and over again. So that's a really important myth, I think, that we want to bust today. But then there are the other ones too. I hear very commonly that, in order to have an eating disorder, somebody has to be underweight by a certain standard. So, by looking at someone, they have to be super thin, or, based on a scale on a certain number, that you have to be under a certain number, an ideal body weight, in order to be considered to have an eating disorder. And people can walk in very medically unstable and be considered to be in what we have historically, as medical doctors said, is a normal weight range for a particular height. So I think that that's improving over time, but I do think that eating disorders come in every shape and size, and that's really important to think about. And eating disorders can happen really at any age too. I talk about how I treat, kids primarily, and we have very young children coming in being treated for eating disorders, and not just for ARFIT, which is what I think most people would think of, right? That really picky eater. Unfortunately, we have 6-year-olds coming in and being treated for anorexia, and then you can have 60-year-olds being treated for eating disorders. It really goes across the lifespan. So eating disorders don't differentiate what your age is and say, I'm going to happen at any particular age. There are certain, I think, ages in which you are more at risk, but it certainly can happen across the age span. And then it's been thought about as a female illness. And it's really, I think that we certainly see in the research females are more represented than males, but I also think that we probably haven't been researching in the ways that we should, and we don't fully understand how males have developed eating disorders and what theirs look like compared to females historically. And so as we gain better understanding of that, we're seeing males and transgender, people represented more in the research and understanding how they are impacted. And it's not a girl thing when it comes to eating disorders. It may look a little different in one gender versus another, but it can certainly impact any age, any gender, and any race. It's not it's not just for people who are white or black. It can really hit any race. So I think that that's really important, that it can cut across socioeconomic, race, gender, age. It can happen to anyone. And so we should be on the lookout for it to hit anyone. I don't know, Dr. Smith, what do you want to add to that? What did I not think about when it comes to myths? Because there are a lot.
Right. I mean, you've provided a very exhaustive list there. But some of the areas I might piggyback on is, I think the issue of the family being at fault is a major one. I try to really emphasize this for people who have parents who are, I would say, above 40, because I remember in my lifetime, when quite young, that eating disorder research and eating disorder treatment, as it was portrayed in the media, turned out that there was a lot of parent blaming going on at that time. I'm talking about the late 70s, early 80s. And so all of the all the national talk shows, all of the times where they have experts on, our own field did a lot of pointing the finger at parents and primarily mothers. And so this became very much a blaming type causation. And so I try to make sure that anybody that I'm working with, that we address that head on, because when I start to feel some resistance from parents about participating in family sessions, or if their kids are worried about how their parents have responded to family sessions in the past, we try to just say that here's one possible stumbling block there is that the way this was portrayed 30 years ago, 40 years ago, was that this was caused primarily by families, by parents, and by mothers especially. And so it was very damaging to the prospect of the family work that is so important. And it's so opposite, I think, of our experience with individuals with eating disorders. Most of the time, we're seeing very loving, supportive families who are doing their best to try to support someone in a very significant crisis. And the normal parenting style that might be perfectly appropriate and helpful in most circumstances may be backfiring when it comes to once somebody has developed an eating disorder. So most of the time, the parents are struggling to find the right way to be supportive, and a child, even if it's an adult child, is trying to figure out, why can't my parents, be supportive for me? And there's a lot of work we do to try to get that connection back together. And if that perception is out there, we really try to bust that myth, like you said, that this is not caused by families. It's not caused. There may be issues to address there in certain circumstances, but these are too complex to be caused by any one person or any one thing. So it's not going to be. It can't be a finger pointing issue. And it's just not accurate. I mean, the vast majority of the time, the families are loving and supportive, and that's what we see most commonly in the treatment settings.
And they're the expert in their children. I always felt like that, even in my pediatric practice, parents are coming in, they are the expert in their child. Now we're going to help bring our expertise in a particular field to help them. But I think it's the same in eating disorders. And so I think partnering with the family around their expertise of their child, and then us bringing in what we can, is the best way that we can typically help our patients.
I think also the myth about, that's out there that over the years, I think you addressed this, but maybe without calling it this, but the myth that eating disorders are not treatable.
Right.
And so even in the field of medicine, we have a lot of colleagues, maybe even especially in other fields other than psychiatry, who commonly just say, well, that's not treatable, is it? Or something to that nature, and that's far from the truth. The research backs this up. The treatment is effective for the majority of individuals, like almost any other mental health issue. There are people who struggle with this chronically and have a lot of resistance, not their own attempting to be resistant, but they're not responding to treatment as well as anyone would like. And certainly there's a percentage of people that are in that category, but the majority of individuals will get effective improvement with their eating disorder with treatment. So that's why it's important to try to make sure we don't have that myth out there that these are not treatable.
Right.
Mm-hmm. And what are some of the most effective treatments for eating disorders?
I'll let you go first.
Well, I think both of us would be happy to talk about this, but there are a couple of approaches that are really considered evidence-based, and we use cognitive behavioral therapy with exposure and response prevention as our main modality of treatment at Rogers, and there's great evidence for that. I think the really beautiful thing about that as well is by using exposures, so having them do things that they're fearful of, and just think about this, right? People have an eating disorder, and we ask them to come in and change their eating right away. So we're asking them to do like the hardest thing possible. So we do this incrementally through exposure work, and it works even if they are malnourished. And I think that the research has shown that as well, which I think is exciting, that we can treat their eating disorder and some of the other things that might be going on with them too, anxiety-wise, with that particular modality too. So that's one of the mainstays that we're going to go after is cognitive behavioral therapy, with the major modality being exposure and response prevention. And then certainly for our younger population, family-based treatment, family-based therapy is the most evidence-based approach, and that's really helping the family, feed their child and help them get through that process. Again, we could do whole talks on both, these approaches, but we're going to try to incorporate parts of FBT into what we're doing as well. Whenever they've been able to, when they're on inpatient, there's a whole other focus. But as we're trying to get them through the other levels of care, we're going to work on getting the family to help them with their eating and refeeding them.
Yes, I think what we're talking about in so far has been the psychotherapy techniques that can be used for treating eating disorders. And what we also have to remember is what Dr. Eken was alluding to there at the end, is that for individuals who need higher levels of programmatic type approaches, it's going to include all these different disciplines we've been talking about. So the approaches that the dietitians take in our system, they would adopt that exposure with response prevention type progression through challenging people with more and more challenging foods to add variety and add volume to what they're doing. And then the medication approaches. So we unfortunately do not have a wealth of different options when it comes to medication that are focused specifically for eating disorders. And a lot of times the medication approaches are going to line up more with what somebody's co-occurring mental health issues are. So their depression or their anxiety might dictate more what the medication choice is. But for some eating disorders or some symptoms and behaviors with eating disorders, there is evidence for medication approaches, and that should be a part of the process too, of assessment and then evaluation for a medication approach to help with it. So then we have obviously different levels of care that people might need. So when you talk about how does someone get a treatment for their eating disorder, these escalations in level of care, or aligning the care that somebody needs with the level of resources that are necessary, like how many of these team members are going to be necessary, and is it necessary to be around the clock, where 24-hour support and help with accountability? How much nursing care does someone need if they're in extreme stages of malnutrition or they have extreme physical health problems? Do they need a medical surgical setting versus more commonly as a psychiatric setting for eating disorder treatment? So there are many different ways of getting help for people with eating disorders. So it involves what is the right level of care or intensity of care that a person needs, And then the approaches, most places that work with people with eating disorders are going to do medication assessments and adjustments and treatment. Most places are going to have a dietitian. Most places are going to have some form of psychotherapy. That's the overarching technique to try to help with the eating disorder. And that's probably where places might vary the most, is on what psychotherapy technique they tend to adopt for their overarching philosophy for treatment. And then, when you go to outpatient levels of care, some places have the luxury of having a clinic that has all of these disciplines in one clinic. More commonly, though, people are having to, kind of piece their treatment team together among clinicians from different clinics. Like the dietitian may work in one clinic, the therapist may work in a different clinic. So, we have a number of different ways of addressing eating disorders and a number of different levels of intensity or care to try to address the eating disorder for individuals who are looking to achieve recovery.
Thank you both. So it looks like we have a few questions that have come in. So I'll ask both of you a couple of those. It looks like one question that we've received a couple of different times for you, Dr. Eken, is can you talk about ARFIT a little bit more?
I could talk about ARFIT all day, to be honest, because it's actually one of my favorite things to treat, because it takes a team, I feel like, and it takes persistence, but there's hope for it too. So ARFIT is, so we do commonly see it in kids, but certainly there are adults walking around who have ARFID as well and probably haven't been diagnosed because it's, like I said, a relatively new diagnosis, maybe in the last 5 years. Dr. Smith, would you say maybe 3 years?
The DSM-5 introduced it.
Yeah, that's right. Okay.
Mm-hmm.
So this is really common for us to see in younger age children as well. That's a common presentation. So they might be pre-adolescent. More common for us to see in boys too, from a malnutrition standpoint. And really common for us to see with co-occurring illnesses like anxiety, OCD, autism spectrum disorders. But these kiddos have a really restricted repertoire of foods that they will eat. And these moms, I feel so bad because, Dr. Smith talked about how we have blamed moms, but these moms are usually exhausted when they come to us. And I shouldn't just say moms because it's not always moms, but often that's who we see. But a parent will come in and just be exhausted because they're trying everything they can to feed this child. And it's often a pattern that, has been going on for a while. And, kids kids have picky stages. Let's be clear about that. That's normal. So like your 3-year-old who's not eating a whole lot and they don't want their peas, don't get too worried about that. But when they really start to restrict and then it's hard to keep weight on them or they are losing weight, we start to get concerned. And one of the parts of the diagnosis is that we're supplementing them. And I always say, take your anorexia hat off here when you're thinking about supplementation, because we think about things like Ensure as something we might supplement with. These parents will find like a food that they can feed their child. It might be a special shake that they make or a special cereal that they find that they'll always eat to try to keep that weight on them. But they might be brand specific when it comes to food. So like I think about some of my kiddos who will eat mac and cheese, but they only eat the Dora the Explorer version of Kraft macaroni and cheese, or they'll only eat chicken nuggets from a specific, takeout place. Like they can only be from like whatever, Wendy's or something. So the level of specificity is pretty extraordinary. So I think about some moms who have run around, like they get the chicken nuggets from Wendy's and the French fries from McDonald's, and that's how they're able to feed their child. And when they lose their protein source, that's commonly when they'll get to us, right? Because it's like they have 1 or 2 protein sources. It might be peanut butter, chicken nuggets is a really common one for us to see too. And if they start to not want to eat that, then it becomes really concerning because it's hard to keep weight on them. And I will say we see these kiddos coming in teenage years too, pretty commonly, because it starts to get more difficult. This was before the pandemic when we were like doing things in person and socially. But it gets more difficult whenever you're trying to go out with your friends and to eat out somewhere and you literally can't eat anything that's served because, right, so many of our social activities revolve around food, birthday parties, going out to eat, any of those things, and they literally can't find things to eat at these activities. So it is a real struggle. I've seen kids, you know, in all various forms of malnutrition from their ARFIT, and young adults who are really struggling as well. So people think about like, oh, maybe it's not so serious, but it's I mean, it can have all the same mortality and morbidity that anorexia does because it leads to such significant malnourishment.
Mm-hmm. Thank you.
I don't know if there's anything else you'd add, Dr. Smith. Yeah.
I think your hope about the success of treatment, I would just echo that you know, because these individuals end up, you know, having typically no body image fears. They're not concerned about the weight gain itself. It's the concern of the anxiety of the food itself. And so we usually can make pretty good progress with at least getting the nutrition in a better place. And then we see that the exposure with response prevention working very well progressively to help them expand the variety of what they eat. But the piece that makes it more likely that they'll experience success even earlier than somebody with anorexia is that they don't have the major body image concerns or fears with the process itself.
In fact, you'll see it's so interesting having people with different eating disorders in our program because, of course, you have our people with anorexia who are so worried, and then you have a kid with ARFID who's like getting very excited about their weight gain and may, in fact, be embarrassed of how underweight they are or that they haven't gone through puberty like their peers because they haven't been able to put on enough weight.
Right.
So it's a really, you know, different experience from that standpoint too.
Mm-hmm.
Mm-hmm. Mm-hmm.
Or haven't been able to play sports because they don't have the energy to do it, and now they have more freedom to do things because they feel better.
Mm-hmm. We have a question about sports. For Dr. Smith, can different experiences cause an eating disorder? Could sports cause an eating disorder?
Well, I think of this similar to the way I mentioned earlier, that I try not to think of there being one thing or one person that can start something as severe and complex as an eating disorder. So can sports be involved as part of the issue? Yes, absolutely. And certainly there are sports and activities that are more common than others to lead to concerns about weight, shape, and body image. So sports that specify, you know, the weight itself, you know, wrestling, boxing, anything where where the weight is known, where you have to be a certain weight category to participate, leads to people trying all sorts of ways to manipulate their weight. And at some point that can turn into an eating disorder. But, you know, I think of these more commonly as we think of most mental health illnesses, as we think of most physical health issues, that there's often a genetic predisposition that we have from our family history. Often in eating disorders, it would mean that there's a strong family history of mood or anxiety disorders or eating disorders. We're going to be more predisposed to developing an eating disorder. And then certain environmental triggers can happen that will precipitate the onset of the symptoms or to turn things into more of a problematic issue. So the examples we've shared earlier, where if you're genetically predisposed to have an eating disorder and then you decide you're going to change your eating to try to become more balanced or to try to change your weight, it may start off with all the right intentions and you may have sufficient control over that initially. And at some point it can reach a point of no return, so to speak, where the person feels out of control. They're continuously thinking about losing weight or about restricting, and it's no longer a healthy balance or something that they feel they have control over. And so that's where that complex interplay of your genetic predisposition and some sort of environmental triggers can lead to the start of an illness for someone.
Mm-hmm. We had another question from someone asking, are eating disorders hereditary? So that kind of goes along the lines of what you're speaking to now.
And it could be hereditary from what we think of in terms of genetic predisposition. We also see, though, that that how food is viewed in the household and how kids experience their parents and their siblings eating, or how food and weight and shape is dealt with in a family system, can affect someone. So so there may be a genetic component to it, but if the family member has been in recovery and they are using a very normalized approach to eating and weight and shape and body image, or maybe very minimal chance that the child would develop an eating disorder. It's more likely, though, if they have that genetic predisposition and the parent is still engaging in some restrictive forms of eating that might be sub-threshold from needing full treatment, but the way that eating is dealt with in the household, or the way that weight, shape, and body image is viewed in the household, can affect someone having a higher risk for developing an eating disorder.
And can I just add on here, because this is something that I talk about a lot with families, is if we think about our own conversations about our own bodies and how we eat and the media, we just think about how much kids can be impacted. Yeah. They're so vulnerable at different points in time. And so I just say, go through a day and think about how many times you might reference how you feel about your own body or your own eating, or how many commercials you see or friends' discussion about paleo, keto, all these things that are healthy, right, but are restrictive ways to eat and can be problematic. And a dieting culture in general is what I feel like is out there a lot. And those messages are just, I feel like, bombard kids a lot. And I think we don't fully, honestly, it wasn't until I started treating eating disorders that I even recognized in my own friends, who I think were pretty normal eaters, how much they discuss their own bodies and their eating. So I think it's just a good exercise to go through. And there is a lot of positive body image stuff out there for kids these days, curriculums and things that they can be involved in that I think are just fantastic. And I say, if you have young kids, get involved in those things, because there's a lot of stuff that can be negative out there about our bodies. And they're what we have, and we should, be grateful for what they do for us.
Thank you. So I'll try to get to a couple more questions here. Let's see, this one I believe might be from a school professional. So in schools, what are appropriate ways to verbally respond to some of the cognitive distortions that kids might verbalize to be supportive? So for example, a student says, I ate X amount of calories and it was too much, but it clearly wasn't too much. Any thoughts on how school professionals can respond?
I'll let you go first. It's a school age first.
Okay. Yeah. So, I don't know what role this person is playing, if they're a counselor or a teacher, but I'll try to go at it from a variety of different ways. In general, I worry that any adolescent speaking of calories in general. So I don't think we should, our weight, our calories, these are things that most of us should be walking around not really understanding and knowing about, unless there's a specific medical condition that we're dealing with, right? So I think, having a conversation with the adolescent maybe about being curious. I always think being curious is a great approach with adolescents in general, about why they're worried about calories, or maybe where that discussion is coming from. It is a great place to start to understand why they may be concerned about calories. And obviously then, going into, yes, the caloric intake, that's a whole other piece. But I think in general, if we're hearing adolescents discuss calories, that's a red flag right there, because that's not a typical discussion that I think is necessary for them to be having. I think that, we could certainly talk about, if you only ate an apple or something for lunch, to also inquire, or, you only ate a certain amount. Also, if they brought up something like that we would want to find out, what's going on with them. Because honestly, it could be for so many reasons too, right? Of why they're not eating well and being curious about that. That's not very specific. It's just hard to give like really general. I don't know, Dr. Smith,
But I
if
think
you would add something in there.
I think it's also speaking to the reason we're hesitating to give a specific answer is because it's always such a minefield for people with eating disorders as to what would be supportive, what would be helpful.
Yeah.
So I really like the suggestion of being curious, and then it depends on what your relationship is with that student.
Right.
If it's somebody you've already had a good relationship with, and that you'd be talking to them anyway. About other things, you can include some curiosity about why that would matter. I mean, there are a lot of things you could say at the moment that might be pretty neutral, like, if you were hungry and that was the amount you needed, then it probably fueled your body. Something very kind of objective or normalized. But I think that curiosity, that this probably is a red flag that something else is going on with the student, and then to just let that curiosity lead you to more supportive questions of them.
Yeah, because I think we have to be careful of what we say is healthy or good or bad too, because that's a whole other labeling thing that can get you off into, like you said, a minefield that's not good.
Thank you. And I think we just have time for one more question, and then to anybody else who have commented with questions that we didn't get to, we will certainly reach back out to answer them in the comments here. So I guess to wrap, if we see signs or symptoms of an eating disorder in someone, what is the best way to reach out for help?
Well, there's not a one specific answer on that one. But what we want to do is, we want to first try to involve, whoever would be the most supportive individuals. And once we've gone past the, supportive questioning and trying to get to a little bit more information about what's going on, and if you're talking about where, like for professional help, I think you would want to look first at your local or your current providers. So most people have a primary care clinician, pediatrician, or family practice clinician, or internal medicine clinician. So that might be a starting point. If somebody's already in counseling or therapy for other mental health issues, that would be another place to check with those individuals, because there might be good local resources to try to address this. There are many eating disorder treatment facilities across the country, but yet there are still many parts of the country that don't have good resources locally. And so but you might be in one of those areas. So your current clinicians would probably know the best local places to try to reach out to. And if you're in an area where you don't have those services already set up, you can certainly call Rogers, and we'll provide the numbers for some of these contacts that'll be available to everybody who's watching. But you can call Rogers for a free screening on eating disorder issues and whether it would meet criteria for needing a higher level of care, or whether it would be something that would be a recommendation for outpatient treatment. And there's certainly resources through the NEDA website and the ANAD website. We want people to also keep in mind that something is more acute and serious in terms of a safety risk for someone, that we'd want you to be able to call 911 and get emergency help for someone if they're suicidal or if they're at risk of harming someone else. We'd also, if there are any medical emergencies that seem like they're taking place, of course, the person should be taken to an emergency room to get medical treatment. So it really depends on what level of severity the person is presenting with, but those are some of the options, and I know we'll be sharing, those resources later as people are signing off.
Absolutely, thank you. So that's all the time we have for today. Thank you to everyone who's joined us and commented with questions. Thank you, Dr. Eken and Dr. Smith, for your time. This was such an incredible conversation. You really shed a lot of light on a really important topic. So thank you very much.
Thank you, Katie, and thanks everyone.
Yeah, thanks for having us. The time flew.
It did. I feel like we could use a whole other hour to keep talking, so appreciate it. And again, for more information and resources on eating disorders and to learn more about treatment at Rogers, you can please visit our website, rogersbh.org. Thank you, everybody. Stay well.